Thank you very much. Good morning all. Welcome to my presentation on Sub-Maximal 2-day CPAT in people living with long COVID to assess post-exertional symptom exacerbation. Follows on quite nicely from the last presentation. I'll just see if I can figure this one out. Yeah, perfect. So before we begin, I'm here representing a team of experts. This is both from our internal organisation at the University of Derby and experts around the world. And our lived experience experts are also very key in every aspect of our work too. So, you knew it was coming. What is long COVID? It's a question we've been asking ourselves for quite a while now. I suppose the key findings from, this one page is that it affects a lot of people. There's a lot of symptoms involved. Preventing acute infection is the only way we know at the moment to prevent long COVID or the risk of developing long COVID. Treatment and management strategies will be as complex as the aontology, but there is a lot we don't know. Again, following on from the last presentation, the PESI, post-exertion malaise, generally affects about 1/3 of people living with long COVID. It describes essentially an exacerbation of symptoms above a personal and variable tolerance threshold. This can be caused by triggers from physical, mental, and psychosocial triggers. Has a drastic impact on quality of life and functional status. For some people, it can be more mild. For some people, it can leave them disabled and bedbound. But yeah, we don't know the exact pathophysiology behind this, but what we do know is that physical exertion and exercise does pose quite a strong risk for some people with high to moderate intensity of this symptom. One way we can look to assess this is through cardiopulmonary exercise testing, as it provides a lot of good physiological data for us. However, using traditional approaches, it does pose quite a high risk. A lot of times the intensities are unsuitable with people living with long COVID, especially with those with this, with PESI, post-exertional malaise. And this can have a really big negative outcome on their functional status and quality of life post taking part in our studies. But we propose that it can be done. One thing we've recently published in a preprint is a sub-maximal 2-day sub-maximal 2-day testing through CPAT. I'll go on to describe what that protocol looks like shortly. But essentially it takes the benefits of doing CPAT testing, but again brings it back to a more appropriate intensities for people living with long COVID. Previous work has looked at 1-day testing maximally. Previous work with MECFS populations has looked at 2-day CPAT testing, but again this has been done maximally. So we'd like to show what can you do with some maximal testing, what findings can come from this. So our aims were to assess the utility of 2 days of maximal CPAT, to determine any 24-hour long effects of that CPAT, and to increase mechanistic understanding of long COVID. Our methods, so we recruited from community contacts, long COVID clinics. Patients were screened extensively for the post-exertional malaise. A big part of that was the DePaul symptoms questionnaire for post-exertional malaise. As part of that, it wasn't suitable with anyone with that moderate to severe risk. This was a multi-centre trial as well, so it took part of the University of Derby, Sheffield Hallam University and Northumbria University. And I can say from the process at University of Derby, 6 patients were excluded at this stage. During the test, patients were monitored consistently and constantly, and it was terminated at any point if participants started to feel unwell, dizzy, or any red flag symptoms came up for them. Okay, so in total, 68 people across 3 sites took part in the study, 37 of which were female, essentially around 68%, which is quite common with the literature that we've seen so far. In terms of our study protocol, it had 4 contact points. We had our initial telephone consultation, which lasted roughly 30 minutes, where we went through eligibility criteria and post-exertional malaise screening. We then moved to the baseline visit, where we took acute COVID-19 details, other demographics, a range of physiological and functional measures, one of which was a 6-minute walking test, which then went on to inform our CPAT testing, which occurred a week later. And then the CPAT testings occurred 1 week later and exactly 24 hours later. In terms of the actual protocol, participants started on one of 3 stratas on 10, 20 or 30 watts to begin with. Intensity rose by 5 watts per minute on a cyclogometer, up to a maximum of 12 minutes. Participants didn't have to do the 12 minutes, but we encouraged them to do it if they could. Cadence was maintained between 60 to 70 RPM. And in terms of the 6-minute walking test informing that intensity, so if they achieved less than 350 meters, they went on strata 1, so that 10 watts. It was strata 2 if they got between 350 to 400 meters, and anything above 450 meters was strata 3 for them, starting at 30 watts. So what were the key results that came from our study? So we didn't see any differences at peak or isotime peak. I suppose we're going to focus here on the first ventilator threshold, and for those that aren't familiar with what we're talking about here, this generally describes when exercise starts to get hard for us, typically. It's when we start to have a greater anaerobic contribution in terms of our energy, but our body can still exercise. It just sort of describes when our legs start to feel a little bit heavy, but our body can cope with that by making a number of physiological adjustments. So what did we find? What did we find? So we found that the first ventilator threshold was reached early into the protocol on both days. A lot of times this was about a minute in, which was quite remarkable. Again, to be clear, from the 68 patients, this is data represented from 39 of those. That's because 39 of those achieved that VT1 on both day 1 and day 2. There were patients that achieved it on just one of the days, but their data isn't included in this data. There was a 7% reduction in oxygen consumption on day 1 versus day 2, a 16% reduction in workload, 28 watts versus 24 watts, a 9% reduction in oxygen pulse, which is the product of stroke volume and arteriovenous difference, and a 3% reduction in end-tidal CO2. So in terms of a bit of the pathophysiology here, we've got a bit of a diagram for the overview of what we're looking at. I won't focus on all of that today, just a few systems here. So I suppose the main finding that came from our study was this impaired physiological response to submaximal exercise, which was exacerbated on that day 2. If we consider the respiratory system here, a couple of findings that I didn't put up on the board here was that breathing frequency between days was unchanged. And also at baseline respiratory muscle function and strength was also within normal ranges. However, we did see that end-tidal CO2 drop on the second day, which is indicative of poorer ventilative function. A previous study looked at long COVID versus controls, and when they took them to max, end-tidal CO2 was lower in the long COVID patients compared to the controls. Other two big findings that I suppose I want to talk about here is that reduction in O2 consumption and reduction in O2 pulse. I suppose focusing a bit more on the latter there. So that was indicative of either a reduction in stroke volume, so a reduction in oxygen delivery, or a reduction in mitochondrial function, again, reduction in oxygen extraction there. Looking back towards more previous CPET testing with people living with long COVID, there was a really good study presented here last year by the Appelman group, and that looked at that maximal testing versus control. They found quite a few, I suppose, similar findings to what we're seeing here. At max, they showed a reduction in maximal oxygen consumption, the reduction in tidal CO2, and also a power output. And they also demonstrated a lower gases, they reached their VT1 a lot earlier in the long COVID group versus controls. So I suppose what I'm demonstrating here is that we've shown utility of using submaximal testing as opposed maybe to the maximal testing. So we show the benefits of using CPET testing, doing a little bit of exercise but in a controlled way while trying to reduce and manage that risk of post-exertional malaise and symptom exacerbation. And we do acknowledge that if we were to do maximal testing, we would very likely have seen an exacerbation of these responses. Some key limitations was that lack of control group, a lack of a comparator group with all the details of what they look like. I think the last study did that really well in terms of documenting what their comparator groups look like, and that's something that we're looking to do in the future. Perfect. Okay, so some conclusions. People with long COVID demonstrate an impaired cardiorespiratory response through CPAP during submaximal cyclogometer exercise. This is as early as evident as the first ventilator threshold. It worsens during additional CPAP 24 hours later, and significant perturbations of normal physiological processes are clear from our data. It's just our references, and thank you very much.